Good afternoon, everyone. Welcome to the celebration of the International Thyroid Awareness Week 2021, brought to you by the Department of Health in partnership with the Iodine Global Network, the World Health Organization, and different societies of the Philippines Thyroid Technical Working Group. I am Dr. Nestor Eric Laplano of the Thyroid Advocacy Council of the Philippine Society of Endocrinology, Diabetes, and Metabolism, and I shall be your scientific chair for this fifth day of this week-long webinar series. We would like to acknowledge first the presence of our distinguished speaker and the participants from different centers for health development, primary care facilities, and everyone who is watching our live streaming via Facebook. Today's exciting discussion is timely and relevant as we physicians face the challenges in terms of limited access of our patients to our clinics and laboratories, as well as the difficulties of conducting telemedicine with our patients with thyroid disorders. But before we proceed with the discussion, I would like to present the webinar guidelines to ensure that this virtual gathering will be enjoyable and productive. First, kindly indicate your agency or organization after your complete name so that we can recognize you accordingly. Keep your microphones on mute during discussions, and please turn off your video during this lecture to save your bandwidth and prevent distraction. Please interact with us and place your questions in the chat box, and we shall address them accordingly in the Q&A forum. And most importantly, please stay present throughout the sessions. I know we are all excited to learn this afternoon, so I won't keep you much longer. Our distinguished speaker for this afternoon finished her internal medicine residency at the De Los Santos Medical Center and subsequently went on to the University of Santo Tomas Hospital for her clinical endocrinology fellowship. After that, she took a postgraduate research fellowship on medical neuroendocrinology and endocrine hypertension at the prestigious National Institutes of Health in Bethesda, Maryland. Presently, she is an assistant professor at the New Era University College of Medicine and practices at the Los Santos Medical Center and Sacred Heart Hospital in Malolos, Bulacan. To walk us through the early detection, prompt referral, and management of thyroid disorders, please help me welcome Dr. Maria Concepcion Gungon. Dr. Gungon, good afternoon, and you may now share your slides.
So good afternoon, everyone. So thank you very much, Dr. Laplano, for that introduction. So I'll be discussing to you early detection, prompt referral, and management of thyroid disorders. Again, good afternoon to everyone watching over the YouTube, the Facebook, as well as here in Zoom. So at the end of the lecture, I hope that you will be able to review the common clinical presentations of thyroid disorders for early detection. We'll be discussing the initial management of common thyroid disorders, and we'll be determining the clinical features that warrant prompt referral to an endocrinologist. So at their simplest, your thyroid conditions can present as thyroid dysfunction or structural abnormalities or both. Your thyroid hormone synthesis is largely regulated by an intact hypothalamus-pituitary and thyroid axis via the TRH secreted from the hypothalamus and the thyrotropin or the TSH from the pituitary gland. So the TRH stimulates the pituitary to release the TSH that in turn stimulates the thyroid to produce T4 and T3. So the entire axis is governed by a negative feedback mechanism such that overproduction of your thyroid hormone will inhibit the axis. So your TSH and the thyroid hormone exist in a log linear relationship. So such that small incremental changes in your T4 results to large incremental changes in the TSH in the opposite direction. So the TSH secretion is exquisitely sensitive to plasma concentration of free thyroid hormones, providing an inherently indirect but precise barometer of thyroid hormone status. So making it in the single best screening test for thyroid hormone dysfunction in an intact HPT axis. So again, your TSH is the best screening test for thyroid dysfunction. So this negative feedback mechanism and the log linear relationship that I've mentioned is illustrated by imagining them at either sides of a seesaw. So with the fulcrum off center, more proximal to your T4 and T3 sides. So take note that such that small incremental changes level of your T4 and T3 will confer large movement across your thyroid, your TSH side. So resulting to an initially elevated TSH in the setting of a low but still normal thyroid hormone. And this condition is what we call subclinical hypothyroidism. So subsequently, your thyroid hormone levels will fall below normal levels with subsequently very high levels of your TSH, so which we term as primary or overt hypothyroidism. Similarly, you can have a very small incremental increase in your T4 and T3 levels, resulting to a suppressed or low TSH levels, which we term as subclinical hyperthyroidism. And lastly, eventually, your thyroid hormone are so high that you have almost imperceptible or undetectable TSH levels as seen in patients with primary or overt hyperthyroidism. So now let us review some of the clinical clues that will help you detect possible thyroid disorders. So one clinical clue is behavior. So when you see a patient in either face-to-face or via online consultation, you try to focus on how they conduct themselves in front of you. Is your patient fidgety? They are hot-tempered, or they wouldn't allow you to finish your question? Or do you see a very slow-moving patient just staring blankly at you, mouth open, and takes forever to answer your question? Take note, anxiety and hyperactivity are associated with hyperthyroidism, while your hypothyroidism is more likely to be associated with low mood. So another clinical clues would be your clothing, weight, as well as your the voice. So focusing on these three features may also help develop your clinical acumen on detecting thyroid disease. In terms of clothing, the clothing may be inappropriate for the current temperature. So patients may experience heat intolerance for hyperthyroidism and cold intolerance for hypothyroidism. The weight, the changes are typically associated with hyperthyroidism for weight loss, while weight gain is associated for hypothyroidism. And changes in the voice, particularly hoarseness, is caused by compression of the larynx due to thyroid gland enlargement, which is sometimes seen in patients with thyroid malignancy. So other clues would be sluggish bedroom voice or a low pitch nasal quality voice that may signify hypothyroidism. So in terms of general inspection, the dryness of the skin as well as eyebrow changes in hypothyroidism may be somehow challenging because right now, kilay is life. And sometimes to evaluate these parameters in an elderly patients, it is somehow difficult. And similarly, they could demonstrate apathetic hyperthyroidism. The presence of myxedematous tissue is characteristically boggy and non-fleeting and is apparent around the eyes, on the dorsa of the hands and feet, and in the supraclavicular fossae. And these may be present in the full-blown hypothyroidism, or sometimes the patient may be just overweight or obese. So how about eye signs? Your upper eyelid retraction is the most common ocular sign of your Graves' disease and in other thyrotoxic states. On the other hand, your exophthalmos refers to the bulging of the eye anteriorly but out of the orbit and may occur in Graves' disease as well. So your lid lag refers to the delay in the descent of the upper eyelid as seen in the video in relation to the eyeball when looking downward, and is likewise most commonly associated with Graves' disease, although it can be present in other thyrotoxic states. Take note the following maneuvers wherein we could assess lid lag. We ask the patient, the upper eyelid will lag behind the eyes downward, and with the sclera being visible between the upper lid margin as well as the corneal limbus. And then in terms of extremities, we could check for the presence of acropathy. So similar in appearance to the clubbing that we sometimes see in patients with heart disease, it is caused by periosteal phalangeal bone overgrowth. You also have your onycholysis. It is the painless detachment of the nail from the nail bed, and your pretibial myxedema, which is an accumulation of the excess glycosaminoglycans in the dermis and the subcutis, presenting as a waxy, discolored induration of the skin on the anterior aspect of the lower legs. So you also have your palmar erythema. It is the reddening of the palms associated with hyperthyroidism, those patients with chronic liver disease, as well as pregnancy. So take note that your thyroid gland, it is the only endocrine gland accessible to physical examination. So in the inspection of the neck, we have to take note whether there is goiter or there are nodules. So whether in telemedicine or in face-to-face consultation, the anatomical landmarks for thyroid inspection are the same. And always remember that the normal thyroid gland should not be visible. So these are the maneuvers for further examining your thyroid gland. So we could ask the patient to swallow some water and observe the movement of the mass. In terms of goiters and thyroglossal cysts, typically they move upward during swallowing. The lymph nodes will typically move very little with swallowing. And lastly, an invasive thyroid malignancy may not move with swallowing with if tethered to surrounding tissues. So it is very important to note that the features of your hypothyroidism manifest indolently. So as you noticed, majority of the common features earlier were on hyperthyroidism, whose symptoms may occur very acutely. So also in small studies on thyroid symptomatology, we see that has very low sensitivity, incorrectly identifying the presence of true hypothyroidism. So in fact, some of these are similarly felt by euthyroid patients. So like yung weight gain, cold intolerance, constipation, it is somehow seen in patients who are euthyroid. So most of the signs and symptoms that we usually ask to assess for the presence of hyperthyroidism have low sensitivity, especially in the elderly. So who may even present with, as mentioned, apathetic hyperthyroidism. Hence, since diagnosis and the management of your thyroid disorders are largely based not only on clinical findings, but take note also on laboratory as well as ancillary procedures, it is very important to brush up on your skills in interpreting thyroid function tests as well as ultrasound findings. So we are going to review the clinical pearls in the management of your thyroid disorders. So I am going to present cases whom you may see in your everyday clinics. So we have our first patient, a 38-year-old female with hyperthyroid symptoms, palpitations, tremors, heat intolerance, and weight loss, presenting with non-tender, diffusely enlarged thyroid gland, exophthalmos, and pretibial myxedema. The patient is tachycardic with a heart rate of 112 beats per minute. So what tests would you request to establish your diagnosis? A, TSH, B, TSH and FT4, C, TSH, FT4, and FT3. So let's answer. So while it is true that the TSH is the most sensitive test for screening thyroid dysfunction, the patient clearly has a telltale signs of Graves' disease. And we will need your T4 levels to establish the thyroid hormone overproduction. Your T3 thyrotoxicosis is somehow rare. So in a possible Graves' disease patient, requesting a T3 usually have no added benefit in establishing the diagnosis. So same patient, this time with results of almost undetectable TSH and a very high FT4 levels. So strictly speaking, is this hyperthyroidism or thyrotoxicosis? So do you need further tests to establish your diagnosis? When you talk about thyrotoxicosis, we are referring to a clinical state that results from high thyroid hormone action in tissues generally due to high tissue thyroid hormone levels. In contrast with your hyperthyroidism, it is a form of thyrotoxicosis due to high synthesis and secretion by the thyroid gland itself. So thyrotoxicosis may be secondary to an increase in the production of your thyroid hormone as seen in patients with Graves' disease, or a destruction of the thyroid follicle resulting to large amounts of thyroid hormone being secreted into the bloodstream as seen in patients with thyroiditis, or even iatrogenic in origin. So to answer the question, the American Thyroid Association recommends that in a patient with a symmetrically enlarged thyroid gland, recent onset orbitopathy, and moderate to severe hyperthyroidism, the diagnosis of your Graves' disease is likely, and further evaluation of hyperthyroidism causation is already unnecessary. So these are the therapeutic modalities for your Graves, including your radioactive iodine therapy, your anti-thyroid medication, as well as surgery. And here we see that your anti-thyroid medication is the most commonly indicated modality, except in cases when there is potential adverse events. So take note that your metimazole is the drug of choice, except in 3 conditions: in patients who are pregnant, during a thyroid storm, or those patients who develop an adverse event after taking the metimazole. So patients should be informed of the side effects of your anti-thyroid medication, preferably in writing, and the necessity of stopping the medication immediately and informing their physician right away. So take note that if there's rash or mild reactions following the intake of your metimazole or other anti-thyroid medication, you may switch it to another ATD. But also do remember the presence of cross-reactivity by 50%. If there is a granulocytosis, thrombocytopenia, or hepatic dysfunction, substitution with another thionamide is not recommended. So again, same patient. The patient was already started on metimazole, 20 milligrams tablet, 1 tablet once a day, and a beta blocker at 10 milligram 3 times a day. So what tests to request after 4 weeks? Is it TSH, your FT4, or both your TSH and FT4? So this illustrates the typical behavior of your TSH and your T4 in Graves' disease. So upon start of your therapy, your FT4 goes down, and therefore, in the first few weeks of therapy, we only check for your FT4 levels to determine response or adequacy of treatment dosage. So your TSH typically remains suppressed and usually goes up only and normalize once your thyroid hormone levels become very low, reflecting depletion of both circulating and stored T4 levels. Therefore, your free T4, your FT4, is the most accurate test to determine efficacy of initiation of treatment during the first few weeks. So same patient, the patient is already being treated for 7 months. Now comes with a normal TSH at 3.8 and a low FT4. This is the first challenge. So because as we discussed earlier in the CISO, we would expect her TSH to go up in the presence of a low FT4. But remember that this patient is being treated with your metimazole and is presently clinically euthyroid. So what are you going to do next? Are you going to stop the metimazole? You're going to decrease the metimazole or you would start levothyroxine. So going back to this illustration, our patient is probably in this phase where the TSH is just starting to go up, coming from a very suppressed and almost undetectable levels in response to almost depleted circulating and stored FT4. So, and therefore, to help us decide the course of action, we need to look at the behavior of the TSH, where it may go up very fast if we do not adjust or even stop the anti-thyroid medication. Your levothyroxine replacement therapy is only indicated when the patient has entered the true hypothyroid phase without the effect of your anti-thyroid medications. So you just need to adjust or even consider stopping the dose of your metimazole and repeat after 2 to 4 weeks to render sufficient clearance of the drug and establish either a remission or overtreatment. So in this case, after 7 months of therapy, it is important to consider TSH in the setting of your FT4 results. So the key concept, take note again, your FT4 is the most accurate diagnostic test to monitor early response to treatment. So pagkakastart pa lang na medication, you request for your FT4. And your TSH recovery may be delayed in Graves' disease. So next case, we have a 27-year-old female with thyrotoxic symptoms, palpitations, tremors, heat intolerance, with a history of cough, colds, and fever 3 weeks prior to consultation. with a non-tender goiter, with suppressed TSH and an elevated T4. So is the thyrotoxicosis secondary to Graves, to toxic multinodular goiter, to toxic adenoma, or subacute thyroiditis? So in the setting of a probable viral infection few weeks ago, a diffuse non-tender goiter, patient may have either your Graves' disease or your subacute thyroiditis. So what test would you request to differentiate between the two? So remember that your Graves' disease, there is overproduction of your thyroid hormone, while in your subacute thyroiditis, thyrotoxicosis is due to the leakage of the thyroid hormone from the destruction of the thyroid follicular cells. So a thyroid ultrasound or biopsy may not categorically establish the diagnosis or establish the difference between the two. So that leaves us to request for your radioactive iodine uptake. So it employs a radioactive isotope of iodine as a tag for the body's stable form of iodine. So they measure the avidity of your thyroid gland for the iodine, and it is reported as a percentage of uptake 4 hours and 2 hours after the iodine or technetium is being given. So elevated uptake may show as highly intense distribution of iodine in the thyroid, as seen in the left figure. And this may be due to the following conditions: your Graves' disease, your toxic adenoma, your multinodular toxic goiter. And on the other hand, your thyrotoxicosis in subacute thyroiditis is due to leakage of the thyroid hormone. So there will be almost imperceptible uptake of iodine as seen in patients with subacute thyroiditis, painless thyroiditis, amiodarone-induced thyroiditis, as well as iatrogenic thyrotoxicosis. So the patient has a low uptake, which is consistent with your subacute thyroiditis, which does not necessitate an anti-thyroid medication because, again, there is no excess thyroid hormone production. So when we manage thyrotoxicosis in patients with thyroiditis, we just alleviate the symptoms by giving beta blockers to control the sympathetic activity. And to address the pain, we could give either your NSAIDs or your steroids. And again, your thionamides are not indicated because no excess thyroid hormone is being produced. So this is our third patient. Our third patient has similar thyrotoxic symptoms, but this time presents with a palpable nodule, about 3.5 centimeter nodule. So what test would you request to establish your diagnosis? So the thyrotoxicosis may be secondary to either Graves' disease, or toxic adenoma, or painless thyroiditis with nodule. So as I've mentioned, she could have a GD, a Graves' disease, a toxic adenoma, an autonomously secreting adenoma, or she could have a thyroiditis with a nodule. So we could request for a radioactive iodine uptake and scan. So there it is reported as films or computer printouts showing the distribution of the uptake. They estimate the anatomic size of the thyroid gland, and they show nodule or areas of intense uptake for hot nodule, decreased uptake for warm nodule, and lastly, a non-uptake in cold nodules. So this time, a combined radioactive iodine uptake with scan will help distinguish the etiology. So she may have a toxic adenoma as seen in the upper figure. In this case, her hyperthyroidism is caused by an autonomously hyperfunctioning hot nodule. Or she could have a Graves' disease as seen in the lower figure and a hypofunctioning or cold nodule. So remember that patients with hyperthyroidism with nodules should undergo radioactive iodine uptake and scan to evaluate for the presence of hypofunctioning nodule, which would usually necessitate fine needle aspiration biopsy to rule out malignancy. Our fourth case, we have a 42-year-old patient presenting with hypothyroid symptoms as well as goiter with high TSH and a low FT4. The most common cause of your primary hypothyroidism, take note, is your autoimmune. And TPO antibody is invariably present. So baseline thyroid ultrasound may be done to see improvement in the size later on, or to detect the presence of nodules that may need or require fine needle aspiration biopsy. However, evaluating for radioactive iodine uptake and scan yield no benefit in terms of etiology. So our fifth case, we have a 54-year-old patient post-total thyroidectomy presenting with hypothyroid symptoms with very high TSH at 100. So the initial take note, what would be the initial replacement dose and what would be our treatment goals for this patient. Always remember that the thyroid hormone replacement is would be multiplied to 1.7 micrograms per kilogram per day times the weight, and the initial dose of the patient would depend on the age, the presence of comorbidities, the level of hypothyroidism, and the goal is to normalize TSH levels. So for an adult patient with primary hypothyroidism, we could initiate the levothyroxine dose again by multiplying the weight of the patient times 1.7. And we could request a repeat TSH after 4 to 6 weeks. If the TSH is more than 4, we could increase the levothyroxine dose by 12.5 to 25 micrograms per day. If the TSH is between 0.5 to 2 and the symptoms already resolved, we could just continue the dose and we could measure the TSH after 6 months and then annually or when the patient becomes symptomatic. And if the TSH is still suppressed at 0.5, we could decrease the dose of the levothyroxine by 12.5 to 25 micrograms per day. So take note that it is reasonable to raise the target TSH to 4 to 6 in persons, in elderly individuals, particularly more than 70 years old. In patients more than 50 years old with cardiac disease, you always start low and slow at 12.5 to 25 micrograms per day and gradually increase every 1 to 2 weeks until the target dose is being reached. If persistently elevated TSH is noted despite increasing your levothyroxine dosage, it is better to evaluate for compliance, interfering conditions, such as also the medications being taken by the patient. So we have our seventh case, a 38-year-old female with occasional palpitations, low TSH, and a normal FT4 level. So what is your diagnosis and will you request further tests for this patient? Are you going to repeat the test? Are you going to request for a thyroid ultrasound, a radioactive iodine uptake and scan, FT3, or TSH receptor antibody? So the diagnosis would be a subclinical hyperthyroidism. So repeating the test would establish persistence of the disease. Requesting for a thyroid ultrasound would help us establish the presence or absence of goiter or nodules. Requesting for a radioactive iodine uptake and scan would differentiate between Graves' disease as well as thyroiditis. Your FT3 would differentiate the diagnosis of T3 thyrotoxicosis, and your TSH receptor antibody would establish the presence of autoimmunity. So again, the most important in subclinical thyroid disorder is to establish persistence. So other causes of low serum TSH levels include a suppressed serum TSH, secondary to your dopamine, to your glucocorticoids, the presence of amphetamine, those psychiatric patients or psychiatric illnesses, the presence of non-thyroidal illness as well. So are we going to treat this patient? So again, once you have established persistence, and this is not thyroiditis, the next issue is treatment. So you treat your subclinical hyperthyroidism with persistent TSH level of less than 0.1 in the setting of the following. So all individuals age more than 65 years old, patients with heart disease or osteoporosis, postmenopausal women not on estrogens or bisphosphonates, significant symptoms of hyperthyroidism. So definitely this patient would be given treatment because the patient is already 68-year-old with persistent low level of your TSH. So another case, case number 9, a 51-year-old male with subclinical hypothyroidism. So do you need further tests for this patient? Remember that autoimmune thyroiditis is the most common cause and TPO antibody is the most sensitive test. It may not always be present in patients with subclinical hypothyroidism. So again, the most common cause for subclinical hypo is still an autoimmune thyroiditis, and your TPO antibody is a sensitive test to detect autoimmunity. So the diagnosis for this patient would be subclinical hypothyroidism. And persistent subclinical hypothyroidism is given levothyroxine treatment if there is persistent subclinical hypothyroidism, which means 2 TSH levels of more than 10. If the TSH is between 4 to 9.9 and there is presence of goiter, there is presence of anti-TPO antibodies, a presence of pregnancy or intent to become pregnant, therapeutic trial for hypothyroid symptoms, there's bipolar disorder or depression, and again, in patients who are infertile, we could start patient with levothyroxine therapy. So again, in elderly individuals with subclinical hypothyroidism, more than 70 years old, usually if the TSH is just less than 10, we would just monitor, we would just observe and repeat the thyroid function test after 6 months. If the TSH is more than 10, we could consider treating the patient if there would be clear symptoms or hypothyroidism or high vascular risks. So in the elderly individuals, again, we should start slow and slow. A small dose of your levothyroxine should be started at 25 or 50 micrograms daily. And the dose would be titrated by 25 micrograms per day every 14 to 21 days until a full replacement dose is reached. So next case, a 43-year-old female with neck mass, however, with normal thyroid function tests. With no family history of cancer. However, there's a palpable 4 centimeter palpable nodule at the lobe at the left lobe. So what is your next best step? Would you request for a thyroid ultrasound, a neck CT scan, a radioactive iodine uptake scan, a fine needle aspiration biopsy, or surgery? So for this patient, remember, so here is a list of suspicious patterns that should alert you when you evaluate thyroid ultrasound. So the estimates of malignancy are also written as well. And the size at which you should consider fine needle aspiration biopsy. Specifically, the presence of one or more of the following is highly suspicious for malignancy. So the presence of irregular margins, the presence of microcalcifications, taller than wide nodules, rim calcifications with small extrusive soft tissue component, and the evidence of extrathyroidal extension. So you should proceed with fine needle aspiration biopsy for 1 centimeter or more nodules. So a 50-year-old patient with goiter with symptoms of mixed hyper and hypothyroid symptoms, and the thyroid function tests that do not follow the typical CISA pattern with low thyroid hormone levels and an inappropriately normal TSH level. So what would be your next step? So although most thyroid function test patterns are easy to interpret and concordant with the clinical assessment of thyroid status, a small but important subset of patients exhibit results that are either discordant with the clinical picture or not congruent with each other. In such cases, you may evaluate their clinical history for the presence of these confounding conditions: the age, pregnancy, thyrotoxin therapy, as well as confounding medications in the presence of non-thyroidal illness, then decide which test is discarded. So this patient appears to have central or secondary hypothyroidism. What will you request to establish your diagnosis for this patient? So this brings up to the last topic, and you should be able to determine when this is the best time to refer promptly to a thyroid specialist. So specifically, these are the conditions that warrant prompt referral to an endocrinologist. So children and infants, patients in whom it is difficult to render and maintain a euthyroid state, pregnant patients, women planning conception, concomitant cardiac disease, the presence of a nodule and other structural changes in the thyroid gland, the presence of other endocrine diseases, particularly in the adrenal as well as the pituitary glands, unusual constellation of thyroid function test results, the unusual causes of thyroid dysfunction, the presence of subclinical thyroid dysfunction, and of course, thyroid emergencies. The key messages for this talk: your thyroid disorders can be detected early through telltale signs and symptoms. The decision on the management of your thyroid disorder should be based on the clinical context and laboratory parameters of your patient. And lastly, certain features in clinical presentation should alert the physician for prompt referral to an endocrinologist. Again, I think this is my last slide. Thank you very much for your kind attention. Good afternoon, everyone.
Okay, thank you. I hope my camera is already on. Okay, so thank you and congratulations, Dr. Maria Concepcion Gungon, for a comprehensive yet practical discussion on thyroid disorders. It's very hard to clump this topic in one session, but you gave us such a clinical approach in the detection and management of these thyroid disorders. So we have a few questions here in the chat box. I'm going to read them out for you. Thank you very much, everyone, for staying up to this point. Okay, so just to emphasize your important points in the discussion, aside from those patients who present with overt signs and symptoms of hyper or hypothyroidism, who are the patients whom you recommend to screen for early detection of thyroid disorder?
Relatively, those patients who have a family history of either a thyroid problem or a thyroid cancer, usually these patients, they come to our clinic because of a family or a mother or a father who has a thyroid problem. So these patients would somehow, it's okay for them to be screened right away to detect early on the presence of a hyperfunctioning or a hypofunctioning thyroid gland. Also in patients who are infertile. So sometimes we receive patients in the clinic because of infertility. So remember that your thyroid hormone, your thyroid function, the thyroid dysfunction is also one of the tests that we screen for this subset of patients.
Okay, thank you. Thank you for that. It added to our knowledge because as we know, some patients with thyroid disorders may actually do not present any signs and symptoms of thyroid dysfunction. And may I also add, probably we may also screen for thyroid dysfunction those young patients with hypertension, or even in those patients with who already had several miscarriages, or even in those patients who are being treated for depression. And thank you, thank you. So,
Pero also, Doctor, yung may presence ng mga PCOS, we also would like to screen them. Yung mga meron tong abnormal uterine bleeding, we would want to check for the thyroid function test. Those elderly patients who present also with arrhythmias. So sometimes, as mentioned in the lecture, they have apathetic hyperthyroidism. They would not present with palpitations, tremors, and then they come in the clinic because of fatal arrhythmias. So these patients would be needed to screen for presence of thyroid dysfunction.
thank you, thank you. So there's really a long list of patients, and we have a data on the presence of thyroid dysfunction here in the Philippines, although that is already yearning for a new one. But we know that subclinical thyroid dysfunction actually is higher in terms of prevalence for our patients rather than the overt thyroid dysfunction. So if we're screening for hypo or hyperthyroidism in areas of limited resources, so shall we just request for a TSH for these patients?
Actually, because sometimes very limited dun sa mga remote areas. So in my practice, because previously I practice in the province, so usually I check for TSH and FT4 right away because it's hard for the patient to come back if the TSH is abnormal, and then we would want them to repeat the FT4 just to take note whether they are really hyper or hypo.
Thank you. So you mentioned earlier that in the gauge, as a gauge to determine the adequacy of dosage of our anti-thyroid drug for our patients with hyperthyroidism. In relation to that, there's a question here: for how long do we usually treat hyperthyroid patients?
So in patients with Graves' disease, usually the treatment would last about 16 to 18 months. However, there are some patients that would need lifelong treatment, and these patients would include yung mga patients male, those patients with large thyroid gland, those patients who have relatively hypertoxic symptoms. Relatively, they will be needing the medication more or less lifelong because most of the patients, particularly those that I've mentioned, sila po yung mga kailangan ng medication more or less lifelong. That is the reason why sometimes we offer these patients yung definitive treatment like your radioactive iodine therapy as well as surgery, because most of them minsan hindi talaga nagre-relapse, hindi talaga nati-treat, hindi talaga nagre-remission.
I agree. And sometimes we see patients on treatment and then they will subsequently go into remission, and then after maybe a few months or even a few years, a trigger will happen and then they will really have these overt hyperthyroid symptoms. So another question here, which is really very relevant as of this time, is it safe for patients taking levothyroxine to receive the vaccine for COVID?
Definitely yes to bakuna. So definitely very safe to be vaccinated yung ating mga hypo as well as hyperthyroid patients. However, those patients na relatively hindi pa po controlled in terms of their thyrotoxic state, I advise them to see their endocrinologist first for them to adjust the medication prior to the vaccination. But relatively, your vaccination, your vaccines are safe, and all patients with Graves' disease should be vaccinated. Yes to bakuna.
Yes, yes, I agree with that. You mentioned that the definitive treatment for hyperthyroidism is either a radioactive iodine therapy or surgery. When do we consider surgery for our hyperthyroid patients?
So this surgery is being indicated or sometimes offered to our patients, particularly those patients na may enlarged thyroid gland, because relatively the radioactive iodine therapy would somehow decrease the size of the thyroid gland by relatively 30 to 50%. So pag medyo malaki na po yung bukol, I think it is just right to offer instead of the radioactive iodine therapy is just proceed with the surgery. And of course, those patients na nagkakaroon ng relapse, those patients na kahit nabigyan na ng radioactive iodine therapy, after 2 years, 3 years, they again develop primary hyperthyroidism, Graves' disease. So these patients, after rendering them euthyroid, I will refer them to surgery to facilitate surgical removal of the thyroid gland.
Mhm. And also it may be also a good option in patients who demonstrate adverse events to your anti-thyroid drugs also.
Yes.
Okay, so here another question. Do you suggest adjustment of medications based on clinical symptomatology alone?
Relatively in my practice, I usually request for a TSH. So we are guided in the management of our patients based on the level of the TSH as well as their symptoms. So I correlate the TSH as well as the symptoms of the patient. But sometimes during this pandemic, di ba, meron pong mga MECQ, may mga patient na sobrang takot to go to the hospital. And as in, hindi mo talaga po sila mapapalabas sa bahay nila. I would just ask their symptoms. And then when they decide already to go to the hospital and do the blood extraction, and that's the time that I adjust the medication.
Thank you. So there's a relevant question here in terms of maintenance medications. What if the patient does not adhere to his or her everyday medications? So is it harmful for that particular patient? Let's start first probably with hyperthyroid patients.
Definitely, if the patient is being maintained on an anti-thyroid medication, definitely the patient needs the anti-thyroid medication. So what are the consequences of stopping the medication if you are hyperthyroid? So the patient would develop palpitations, tremors, and the dreaded complication would be fatal arrhythmias. So definitely it is not advisable to stop your anti-thyroid medication, and you allow your endocrinologist, your doctor to adjust your medication.
Okay, for hypothyroid, can they do alternating intake of the levothyroxine? For example, if they forgot today, can they take this today's dose tomorrow?
So relatively, your levothyroxine has a long half-life. So 7 days yung kanyang half-life. So I usually advise my patient that this is a medication that if ever you forget to take your dose today, you could double your dose tomorrow. Actually, may mga studies na pwede siyang inumin ng sabay-sabay, yung 7 tablets in one day. However, syempre nagpipik siya and it might cause palpitations or tremors if you would take the 7 tablets right away. So just inform the patient that if ever they missed a dose for this day, they could double the dose the following day.
Thank you. Thank you for that clinical pearl. It will certainly help our patients adhere to their regimen in terms of that particular tip to our patients. For nodules, how often do you suggest that we repeat the biopsy of our thyroid nodules? For example, they underwent a biopsy and then it came out negative for malignancy. How often or when will the next biopsy be done?
So usually in terms of thyroid nodules, if the biopsy is negative, we would just request for the thyroid ultrasound every 6 months, and we would take note of the itsura of the characteristic of the nodule, whether it is indicated to biopsy again that particular nodule.
Okay, thank you. Thank you for that uh, Pearl. For pregnant patients, do you suggest routine screening?
For pregnant patients, it is not suggested by your American College of Gynecology as well as the FSRM. There is a debate between whether your TSH should be part of the screening for reproductive age. Remember that the presence of overt hypothyroidism is just about 1% of the reproductive age. Pero dun po nagkakatalo dun sa subclinical thyroid disorders. So usually the prevalence of that part is about 3 to 15%. So dun sa subclinical part, baka it is good to screen these patients. However, based on the guidelines, ang mga nire-recommend for a possible screening for pregnant patients are those nung mga high risk. So when we talk about high risk, syempre yung mga previously may thyroid problem na, those patients who have goiter, those patients who have thyroid nodules, may history of infertility, nahulugan, na-diagnosed with APAS before. So those patients should be screened.
Okay, thank you. Thank you. So I think we are all sated and busog with this discussion. And so again, thank you, Dr. Gungon, for that enriching discussion. And thank you, everyone, for staying up to this point to officially end this successful 5-day webinar series. We would like to warmly welcome Dr. Nemencio A. Nicodemus Jr., the President of the Philippine Thyroid Association, to give us the closing remarks. Dr.
Thank you very
Nicodemus.
much. Thank you very much, Dr. Gongon. And also, thank you very much, Dr. Eric Laplano. It is indeed a very exciting week for all of us. This year's International Thyroid Awareness Week was made very much memorable because of the collaboration of several organizations. And of course, the Philippine Thyroid Association, being the lead organization for this year, is very much grateful to everyone who collaborated with us, particularly the Department of Health, who has been really very helpful in ensuring that all the important stakeholders will be able to collaborate and join us in this week's celebration. As you saw, we started our first day of this celebration with none other than, of course, the Department of Health Secretary, Dr. Duque, to give us, of course, the key message for our National Thyroid Prevention and Control Program. But then, the several days gave us several very important personalities, not just in the field of medicine, but also in the field of education. And so we are also very much uh, grateful to our colleagues in the non-medical field who joined us in this year's celebration of the International Thyroid Awareness Week. But before I tell you that everything is already done, I would like to invite everyone for tomorrow because we have our lay forum tomorrow at 3 o'clock. And this is sponsored by the Philippine Thyroid Association. And I would like to invite everyone, please ask your patients to join us tomorrow at 3 o'clock, from 3 to 4 o'clock in the afternoon, as we have our thyroid lay forum, and we will have two very important lectures that will be shared tomorrow. And we have also two very distinguished speakers. The first talk tomorrow during the lay forum will be iodine deficiency and the effect on the pregnant mother and her baby. So kung meron po tayong mga pasyente na kilala natin na buntis ngayon or nagbabalak magka-baby in the next coming months, and they want to know the effect of iodine on the pregnancy, then I encourage you to invite your patients to join and visit the Philippine Thyroid Association Facebook page to be able to view our lay forum for tomorrow, because the first lecture will be given to us by Dr. Eric Mendoza. Then we will have a second lecture, and again to be given by another distinguished personality. This time, we will understand iodized salt as an effective and easy way to correct iodine deficiency disorders. Because this entire week, we have been educated on the role of iodine, its effect not just on the mother but also on the baby. Ang tanong ngayon, can iodine deficiency be corrected using iodized salt? And to give us this talk for the lay tomorrow will be none other than Dr. Teofilo San Luis Jr. And so I would encourage everyone to invite your friends, your family to our lay forum tomorrow at 3 o'clock in the afternoon by visiting the Facebook page of the Philippine Thyroid Association. And so by way of saying goodbye, I would like to thank all our collaborators for our International Thyroid Awareness Week celebration. You have made this year extra special because of the collaboration that we have. And I'm sure all our participants for the last 5 days have been very much enlightened on the role of iodine on the woman and her child. And so I would like to close our International Thyroid Awareness Week celebration for doctors and health workers and invite everyone tomorrow for the lay forum. And thank you very much for all our speakers for the past several days. And we do hope that you learned a lot from all our speakers. Thank you very much.
Thank you, Dr. Nicodemus, for that well-deserved talk. At this point, we would like to call Dr. Clarito Cairo Jr., the Medical Officer 4 of the Cancer Control Division, to present the certificates of appreciation to our speakers. Dr. Cairo?
Yes, thank you, Dr. Eric. Good afternoon, everyone. The Department of Health uh, awards the Certificate of Appreciation to Dr. Maria Concepcion Gungon in grateful appreciation of her invaluable contribution as our distinguished resource speaker on early detection, prompt referral, and management of thyroid disorders on May 28, 2021, during the week-long virtual observance of International Thyroid Awareness Week and World Thyroid Day from May 24 to 29, 2021. Signed by Dr. Maria Rosario Vergere, our Undersecretary of Health, Public Health Services Team, Department of Health. Thank you very much, Dr. Gungon. Over to you, Dr. Eric.
Thank you, Dr. Cairo, to our guest speaker, and especially to all the participants for joining us in this advocacy. And let us now have a quick photo documentation. Kindly please open your cameras and let me call on Miss Dolly Manalastas from DOH to facilitate this photo op.
Hello, good afternoon. So we will have a quick photo documentation. So please turn on your camera. So we have a total of 6 slides. Okay, so we'll have the first one. 1, 2, 3, smile. And then the next slide. The third one, keep your cameras open. The fourth one. The fifth. And the sixth. All covered, Dr. Eric. Over to you.
Thank you. Before I say adieu, please invite your patients again for an exciting lay forum tomorrow at 3 p.m. as we have invited, as mentioned earlier, distinguished speakers from the Philippine Thyroid Association and the Iodine Global Network. This lay forum, which will be spearheaded by the Philippine Thyroid Association, shall be live streamed in their FB page and will serve as the culminating activity of the International Thyroid Awareness Week and will be followed by the executive summary of our Thyroid Week celebration. So you may also scan this QR code or just visit the Philippine Thyroid Association Facebook page. Finally, I enjoin everyone to please let us know how we can further improve our learning sessions by completing this feedback survey through this link or scan the QR code. Your certificates will be sent upon completion of this survey. Thank you once again and have a happy weekend.